to our Congress reporting from the SABCS. The SABCS is the San Antonio Breast Cancer Symposium. And on behalf of Mamma Mia and patients today, I warmly welcome Marc Thill from the Agaplesion Markus Hospital in Frankfurt. My name is Alexandra from Korff, and Marc, would you quickly introduce yourself?
Yeah, so you already said where I'm located. I'm a gynecologic oncologist by training, and I'm heading a department of gynecology and gynecologic oncology at this Agaplesion Markus Hospital in Frankfurt, focusing on cancer patients. This is the reason why we gave up obstetrics a couple of years ago. And this is the reason why I really have to attend the San Antonio Breast Cancer Symposium. And I had my 20th anniversary there, so we're all getting older.
And it's the largest of all the breast cancer conferences, so the place to be, right?
This is the place to be, so this is why we're here.
Well, I wasn't there, but
now we're
before
here.
The conference, we discussed the abstracts that have been discussed. Marc went to San Antonio, and then we sat together and decided on the most important studies from a patient perspective. And here we go with the HER2 positive.
That's it. That's the case. So first, a short disclaimer, and then afterwards, my potential conflicts of interest. And then we start with the HR positive disease. And the first study we want to talk about is called the TRAIN-3 study. Again, a study that tries to implement imaging in the neoadjuvant setting to predict an early response. So I think it's very important, very crucial for all of us to get an idea as early as possible. Where is the tumor that responds to our therapy? And in the end, after surgery, where the pathologist finds out do we have a pathological complete response or not, we will have the truth after therapy. But the story is, do I really need all the chemotherapy to reach a pathological complete response, or can I make controls in between with an image marker like MRI, for example, or PET-CT scan? So there was another study published 2 years ago with PET-CT scan. So here we are with the TRAIN-3 study. As said, HR positive disease, usually treated neoadjuvantly. And this is the study design. You see nearly 500 patients. And the story was, as I said, so where are the patients where I don't need the full number of chemotherapy cycles, and what was done was three cycles of chemotherapy, of course, then with the 2 antibodies were given to the patients, and then there was an early measurement with an MRI. So the radiologist was asked, do you see that the tumor disappeared just after 3 cycles? If not, 3 cycles in addition. If not, 3 cycles in addition. And then the patients had to undergo surgery. So endpoint was event-free survival at 3 years. And the question is right now, so how many patients had to undergo only 3 cycles of chemotherapy to receive a pathologic complete response? So again, some more information. What does it mean? Anti-HER2 directed therapy. What is image guide optimization? I think I explained that very, very briefly, that we are able to go to the results. And when talking about HR positive disease, then we have to differentiate between hormone receptor negative and the triple positives. The hormone receptor positive, from what we know, that these patients maybe are over-treated with chemotherapy, so we have to figure out is there something else, and therefore the patients having an HR negative HER2 positive disease, they respond to chemotherapy better, and this is the reason why you see that a third of patients, so every third of our patients in this study received a part CR after 1 up to 3 cycles of chemotherapy. So this is really great news. And for the HR positive population, every 6th patient. So the explanation is, as I said, that these tumors are not so sensitive to chemotherapy. But the most important thing is that I'm able to predict with an MRI, and this was done much, much better in the triple negative disease and not in the HR positive disease. So to conclude at this point, if an MRI was used, the the early response was predicted by MRI, but only in the HR negative, HER2 positive disease and not in the triple positive subgroup. Some more parameters, some more data regarding the event-free survival, and there you see that coming to the top line, the 3-year event-free survival was similar between the hormone receptor positive and negative. So this is really good news. And when we look down, then we see that all the patients having just 3 or 4 up to 6 or 7 up to 9 cycles, they had no difference regarding the event-free survival. But of course, take into account that more patients with an HR negative HER2 positive disease had a lower number of chemotherapy cycles. This goes along with a lower toxicity and their side effects. Of course, if you don't get or if you get less chemotherapy, then of course you have less side effects, and this is shown in this slide.
Which is a very positive development, because if you think about it, a few years ago, everybody would get the same therapy. Like in the early days, it was breast cancer, and then there's differentiation. And now we're even going into, okay, do you need all the cycles of this? Because or at least I get the feeling sometimes it's if you have an overtherapy, why not try to avoid it? On the other side, you will always have the feeling, no, I want everything. Please give me everything, because I don't want to take the risk that because I didn't do enough cycles, it might come back quickly. It's difficult. It's difficult again, but that's why we decided this is so important to prove the point why it could work with less cycles.
Yeah, this story is chemotherapy for everyone having an HR positive disease. Then where can I avoid anthracyclines as chemotherapy? Where can I avoid a combination chemo where I'm able to avoid the numbers of cycles and so on? So we're talking about a de-escalation that goes further on. So therefore, this is very important to study. So I think this is, to my knowledge now, the 3rd study that was presented using an image marker, so to predict early response with an MRI or CT DNA. So this is something we discussed intensively in the triple negative take. So you are recommended to watch this as well. So the idea is always where I'm able to predict my early response to lower the chemotherapy, and this is, I think, a big step forward, having this trial now in addition.
It's always good also to question your doctors. I mean, you never know how if it's the state-of-the-art treatment that you're getting, and why not ask? Is it really necessary? And then you can discuss this with your team.
Yeah, definitely. Very, very exciting data. So let's go to the next abstract. And as I said, the triple positives. I think we are over treating this patient subgroup with chemotherapy, because there are a lot of patients where chemotherapy is not needed. And Luca Maloni from Italy presented this very nice data using an endocrine-based treatment. That means endocrine therapy plus the targeted therapy, so CDK4/6 inhibitor, plus the two antibodies versus chemotherapy. So, I mean, this is the story where I'm able to avoid chemotherapy. And this is the TOUCH study. The TOUCH study was conducted only in postmenopausal patients. I have to say that most of the patients were elderly patients with an age of 65 and older. There was a geriatric assessment done in a parallel manner to the documentation of efficacy and side effects, so just to get an idea. So where are the more fragile patients? And so there was less chemotherapy given. So this is seeing here. So chemotherapy was just paclitaxel. So there was not a combination chemotherapy. So the tumor was just 1 centimeter and bigger. So a patient population from what we say, well, okay, let's try it out. Let's be brave enough to avoid chemotherapy. We wouldn't maybe do in younger patients where we know that avoiding any combination chemotherapy in a neoadjuvant setting will lead later on to problems when there is a residual tumor left, and then we have to talk about the next treatment step. So, but focusing on that. So this is the story. What is the value of a CDK4/6 inhibitor, so palbociclib, in combination with an anti-hormonal treatment plus the two HER2-directed antibodies in comparison to paclitaxel standard treatment with the two HER2-directed antibodies done in a neoadjuvant setting. So the goal is pathologic complete response. Here you see the explanations to the different compounds that has been used in the trial, and here you get some more information regarding the patient characteristics. As I said, so most of the patients had an age of 65 and older. Only 26% of the patients were younger than 65. And two arms. So this is a phase 2 study. So these are always studies to get ideas. Is it worth to maybe conduct a bigger study? So therefore, we only have 145 patients within this trial. Of course, when I talk about over-treatment, avoiding of chemotherapy, then of course it's of a high interest. How was the discontinuation rate? And the discontinuation rate is always higher when chemotherapy is given due to toxicity. And here we see that 16% of these patients discontinued very early due to side effects of the chemotherapy. When compared, and this is the second line that is highlighted with this red rectangle, and compared to just 3% for the hormone receptor, for the anti-hormonal treatment in combination with the CDK4/6 inhibitors. So therefore, we would say, well, less side effects, cool, yeah. No chemotherapy, again, very cool. But does this lead to comparable efficacy? And this is the next slide, and here we see the pathologic complete response, and we do see that there is no difference. So we have
brilliant news.
Yeah, so this is a PAT-CR of 33%. We wouldn't expect more because just one chemotherapy compound was given, not a combination, and endocrine therapy. But this is how we are able to start maybe a following trial based on these results. So as you said, so great news. I don't need chemo to get the same PAT-CR in this patient group. And this is something where I said I really love this study, the TOUCH study. So it was a touchdown for me that we finally someone did this trial in triple positive disease.
Yeah, thank you to Italy, right?
Thanks to Italy, because the Italian guys, they always say, I love women, and because then they are able to conduct these trials. No. Coming back, so yeah, my conclusion is very clear. You are able to read that. So no difference regarding a PAT-CR. And what does this mean for every day? We do have, there was another study in metastatic disease, so you recommend to watch the takes for metastatic disease. Nadia Habeck is summarizing that, and there's the Patina study, definitely part of this summary. So we had seen the very positive trial, metastatic disease. Now we have a hypothesis generating trial here. So triple positive disease does not really need chemotherapy, and we have to find out where are these patients, and this is the first step. So therefore, very attractive, but not to be used at the moment. So this has something to do with approval, but we do have data, and I think in some cases we may use this information, maybe write application letters to the health insurance, but this is done on a very individual base. Alex, this was the part for HER2 positive disease.
Yes. Thank you very much for taking us through. There were some breaking results, I think, or at least something that we have to watch carefully and take to our doctors to discuss. So thank you very much for taking your time, explaining everything, and I look forward to our next take.